Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. In this episode, we explore a case study looking at when and how to optimize ART with novel agents. I'm joined by Dr. Gregory Huhn from Rush University Medical Center in Chicago. For more information about this program and to follow along with the slides, or to register for one of our live sessions in this series, please visit the links in the show notes for this episode. And to get access to all of our new podcast episodes, subscribe to the CCO Infectious Disease podcast on Apple Podcast, Google Podcast, or Spotify. Now let's get started with another case study from Dr. Huhn.
This is going to be a little bit more intense here. And we see these patients that again, they've been living with HIV for 30, 40 years. This is a 52-year-old gentleman diagnosed in 1995. Suffered through depression, substance use, intermittent housing, so housing insecurity, experienced viremia on dual nuke therapy, so combination dual nuke therapy. Again, early on, maybe 1995, we found that's in 1996. This is when we had, again, the revolution with combination therapy with the early protease inhibitors. So he did get finally, again, he sort of matriculated on to dual nukes with a series of third drugs, indinavir, nalfinavir, nevirapine, efavirenz, the indinavir, nalfinavir, hard to tolerate, multiple pills a day, nevirapine, efavirenz, easier, right? Especially efavirenz once a day. But from 2013 to 2015, he had intermittent suppression on boosted darunavir with raltegravir and maraviroc. We're going to get to the genotypes. He had poor adherence on this multi-drug regimen, BID dosing with raltegravir and maraviroc. So he got a genotype, again, he was intermittently suppressed, got a genotype in 2015, pan-resistant to nukes, non-nukes, and PIs, being on raltegravir. Intermittent resistance developed in N155H, and he's dual mixed, because again, maraviroc, poor adherence, he progressed to be a dual mixed CXCR4 with CCR5. So he was switched to BID darunavir, FTC TAF with BID dolutegravir with improved adherence. He got undetectable. You could actually, again, flex up to BID dolutegravir and overcome that N155H. BID darunavir, he didn't have those mutations full scale to darunavir. That's going to be effective. And then he recycled nukes. So he's at a CD4 of 390. He's undetectable. More background history, treated for gonorrhea 6 months ago, no other comorbidities. So again, these are the questions now. Optimizing the patient's quality of life. How satisfied are you with your current ART? Let's see if we can construct a best regimen for you. And now that you're with virologic suppression for several years, can we simplify and can we consider injectable ART? So when you take a look at, we said he had a resistance test in 2015. High level resistance to the nukes. He's on that bad TAM pathway, the M41L, with the 210 and the 215. He has the M184V, not surprising, with going back to his dual nukes, again, back from 1995. He's failed the non-nukes, really every single one. The PIs, again, low-level resistance to darunavir, so you do have activity with BID darunavir. And the integrase inhibitors, because he really kind of burned through the raltegravir, has high-level resistance, even with the ART263K with the bictegravir. But again, he's on BID dolutegravir. You can overcome some of these integrase inhibitor mutations with BID darunavir, for which he's taken and he's been successful so far. Of note, he does have that profile, which is dual mixed. All right, so how do we break this down? So drugs with existing drug class resistance may have residual activity. Bictegravir, dolutegravir, again, we talked about dolutegravir, increasing that to twice daily to overcome some of those integrase resistance mutations. Boosted darunavir, you really kind of need 3 of the signature mutations. He did not have those 3, so you can actually do BID darunavir. He found success with that, and consider these recycled nukes, again, coming out of what we saw with the BASEN trial, the Nadia trial, the second-line trial, some of those trials in sub-Saharan Africa. And then the novel mechanisms. Maraviroc BID, that's not an option. He's not R5 only. Infuvritide, an agent that's been around for a long, long time as far as an entry inhibitor. Fostemsavir, we'll get into that slide next. Ibalizumab, again, another anti-CD4 receptor inhibitor, and then lenacapavir as a capsid inhibitor. The latest that we have in our portfolio, subcutaneous Q6-month dosing. So let's take a look at the BRIGHTE study. So this is fostemsavir, and this is a BID drug, new class. These were patients that were, so this is an attachment inhibitor, new patients that are viremic, that they have 1 to 2 remaining, there was 2 different groups, 1 to 2 remaining active drugs, at least 1 fully active, but you can't construct a routine regimen around other remaining agents. Those patients were randomized to, let's say, fostemsavir itself to look for activity at day 8 with failing regimen versus placebo. So you really want to see if the fostemsavir had that activity. That was sort of primary endpoint. And then they moved on to their optimized background regimen with fostemsavir. After 96 weeks, 60% of those patients were virologically suppressed. So that's a success. Active drug, fostemsavir, with usually 1 other active drug. So it was a 2-drug regimen. Non-randomized cohort, no remaining ARV classes. So no fully active regimens. So here you say, can fostemsavir with any type of optimized background regimen find virologic success? And in about a third of patients they did, 37% after 2 weeks. So again, new class as an active agent can really find success even in those where they may have no other active agents. Ibalizumab. So this is an IV infusion, anti-CD4 receptor, heavily treatment experienced patients. So this is a monoclonal, because really as an IV agent and knowing with patients with really very few options, these are hard patients to find, but you want to find activity in the drug. So these are patients that are viremic, over 1,000. They're on stable ART for at least 8 weeks and receiving any ART for 6 months. They're resistant to at least 1 ARV from 3 different classes. They have sensitivity to at least 1 ARV. So this is an add-on. So it would be perhaps 2 drugs with activity. So there was a loading dose of ibalizumab, and then it's every 2 weeks. And after 96 weeks, undetectable 56%. So again, this can be successful as an add-on for patients that have very few options. And so some of the kind of details on administration here. Fostemsavir, this is BID, with or without food, got to take it whole, can't crush or cut or split the tablets. Nausea is a common AE, over 5%, but it's really not rate limiting for patients to stay on the drug. Ibalizumab, again, this is IV. So at the loading dose, this is a 1-hour observation. It can either be given 30 minutes as an infusion or a 90-minute push. And then the maintenance dose, which is a lower dose every 2 weeks, this is a 15-minute observation post-dose, 15-minute infusion, or just a push for 30 seconds. So much more patient-friendly. Most common AEs, diarrhea, dizziness, nausea, rash, that's over 5%. But again, fairly well tolerated. Really, patients do need to be, though, adherent to the Q2-week dosing. And then finally, CAPELLA. So this is lenacapavir. So this is a capsid inhibitor, sort of a 3 strategic inhibitory type of mechanism of action with nuclear transport, capsid viral composition, and then egress from the T cell, where it disrupts at 3 different steps. So a very compelling new drug category, Q6 months. The CAPELLA study took patients, again, viremic over 400, resistant to at least 2 classes out of the 3 to 4 main ARV classes, nukes, non-nukes, PIs, integrase inhibitors. Had to have less than 2 fully active agents of the 4 main classes. Again, harder to find these patients, N of 72. They repeated an RNA. So they wanted to know, were patients just not taking their medications? And if they actually had a decline, at least a half-log decline, or got under 400, they went to the non-randomized group. The randomized group was the ones that really had very few options. They did not get a virologic response when they rechecked the RNA. So really, these are, their background regimen was probably not active. And so they went on to functional monotherapy to demonstrate, validate activity of lenacapavir versus placebo. And then they all went on to maintenance. And then versus on the non-randomized side, they just went straight to the optimized background regimen with oral lenacapavir induction. That is 600 milligrams on day 1 and day 2, and then 300 milligrams on day 8. Then they went to subcutaneous dosing, and then every 6 months. At the end of 1 year, 83% in the randomized group were virologically suppressed. And then at 2 years, 62% virologically suppressed in that randomized group. And so again, really exciting news for a very long-acting agent. Subcutaneous dosing needs to be done in the healthcare setting. It's 2 different needles, but every 6 months to get patients towards success with an optimized background regimen. So the importance here is that optimized background regimen is important because there was emergence of lenacapavir mutations in 14 out of the 72 participants, 9 within the first year, 5 with the rollover into the second year. 4 of those patients had no active drugs in their optimized background regimen, and then the other 10 just had inadequate adherence. So you really, it works best if you have at least one active drug to protect it. 7 of these 14 patients actually did resuppress, again, as they were re-educated on the importance of adherence with their background regimen. Now, when it comes to injection site reactions, most of these were mild to moderate with swelling, erythema, pain. There was 6 grade 3 adverse events, and among 4 of those due to an injection site reaction. 1 patient did discontinue because of injection site reaction. That was a grade 1 nodule. Patients should know these are subcutaneous injections. The nodules at the end duration can occur, 30% nodules, in duration 15%. But if they do occur, they're long lasting. Patients can kind of feel them. You may not see them, but they can feel them. And they may go on again for months and months. So patients do need to be aware of that. So take home points here. Healthcare providers should assess patient satisfaction with their HIV management. Really at every visit, constantly reassess whether that current ART regimen remains the best option for them. Oral ART may be simplified even with the prior nuke resistance. So recycled nukes still will protect activity for integrase inhibitor, dolutegravir, boosted darunavir, using these ART regimens that again may include highly active resistance. So we've seen that coming out of the NADIA and the VSEND and second line trial. Novel ART regimens, they can be considered for optimized ART for extensive drug resistance. So we've seen that fostemsavir, ibalizumab, lenacapavir. And then finally, once ART is optimized, really those opportunities to optimize overall health, every visit, that should really be considered for all patients.
Thank you very much to Dr. Huhn, and thank you to our listeners for joining in. As a reminder, to view the full program entitled Contemporary HIV Treatment and Prevention 2024, click on the links in the show notes for this episode. Thank you, and we'll see you soon on the next podcast.